maybe this time last year or maybe a bit earlier, Mounjaro hit the scene. And that seemed to me to be a game changer.
Yes, and it's a different class of drug. So we know weight is associated, excess weight is associated with over 200 different medical conditions. So as people lose weight, 5%, 10%, 15%, we see benefits to their blood pressure, their blood sugar levels. But the more you get to the 15 and 20%, you're reducing those and also reducing risk of premature death.
So how do you see the future? And there's a lot of people out there who don't like injections. Is there an oral form on the horizon? Hello, I'm Guy Slater, Chief Medical Officer for Roxy+Rex. In a series of podcasts, I'm going to be joined by different medical experts to discuss obesity and its treatment. Today, I'm delighted to be joined by Dr Eveleigh Nicholson, an NHS consultant endocrinologist with an interest in obesity and diabetes. Today, we're going to talk about all things GLP-1 medication, how they work, who they're for, and how effective they are. So maybe, Eveleigh, it's great to see you. Maybe you could introduce yourself, tell us about your interest.
Yeah, thanks, Guy. So my name's Eveleigh. I'm an NHS consultant, so I work full-time. I specialise in diabetes and endocrinology, which is the study of hormones. And within that, I have a particular interest in helping people with obesity and looking after people who are having weight loss surgery, so bariatric medicine.
Brilliant. Right, I guess we start at the beginning. How does GLP-1 medication work?
Yeah, so GLP-1 medication has been around for well over 10 years now. It's a medication that was originally developed to help treat people living with type 2 diabetes. Now, GLP-1 is a hormone that we all have. It's a hormone that's produced by our guts, and it helps our body regulate blood sugars by encouraging our body to produce insulin, and that's why it was developed for type 2 diabetes. But when they did those studies, they noticed that people also lost weight. And that's really how the interest and the use of GLP-1s in weight loss came about. And so more studies were done, and that's how we now use GLP-1s for treatment. But how it works is GLP-1 is a hormone, and it helps your body feel full when you eat. It helps stop you feeling hungry, and it also slows down the passage of food from your stomach down into your bowels, which also helps with that feeling of feeling full.
Okay, so from a patient perspective, everything that's so difficult about dieting, struggling with appetite, never feeling full, it addresses those issues?
Yeah, so in our body, as I said, we've got lots of hormones. We have one hormone in particular called ghrelin that helps or makes us feel hungry. And we have lots of different hormones that tries to make us not feel hungry to try and suppress our appetite. Some of those are formed from the gut, some of those come from our fat tissue, and some come from an organ called the pancreas. So by using medications that mimic those hormones, we can give someone treatment to help them enhance the way our body already works in making you feel less hungry and feeling full.
Okay, no, that's brilliant. So for me, this is the first time in my 20-year career looking after patients who struggle with obesity that we've had effective medication. But a few years ago, it seemed to start with Saxenda liraglutide. That didn't seem to be terribly effective. Maybe patients didn't tolerate it. Was that your experience?
So liraglutide is a type of GLP-1 medication. And as I said, it was developed actually for type 2 diabetes, and then it was found to help with weight loss. And then the studies were done in weight loss. And it showed that people that took it could lose about 6% of their total body weight, which nowadays doesn't sound like a lot, but actually at the time was by far the most effective treatment for weight loss from a medication point of view. And so that was really the start point. It was well tolerated. There are side effects of GLP-1s, and I suspect we'll talk about them that are quite similar for all of them. But, 6% is, very similar to what studies have shown us for things like dieting, but of course is nowhere near what perhaps could be achieved with weight loss surgery. So it was a good start, but obviously wasn't, in the grand scheme of things, hugely effective.
And then more recently, we had semaglutide, Wegovy for weight loss, Ozempic for diabetics. And that seemed to really capture the public's imagination, and it really seemed to snowball at that time. Again, you found the same?
Yeah, so again, the difference, so semaglutide is another type of GLP-1 medication, again developed for diabetes. We still use it for type 2 diabetes. And this showed more like 16% weight loss. So again, a much bigger increase in weight loss compared to the liraglutide, and a significant amount of weight. We know that once people lose 5% more of their body weight, you start to see the medical improvements. So 15% was really quite significant. Again, came with side effects, more side effects than perhaps we saw in the liraglutide population. And side effects are relatively common with these class of drugs. But again, that was quite a significant step change really for medication for weight loss.
Okay. And again, my experience was that maybe sometimes at the higher doses, people found side effects really difficult, and it led to them stopping the medication.
Yeah, and I think that's common for medication full stop, is that you tend to see more side effects come through. Side effects for GLP-1s, because they work on your gut, are mainly gut-related side effects. So people feel nauseated, they might vomit, gut disturbance, so things like diarrhea or constipation, burping more and reflux. So the higher the dose, the more strong the medication is, the more people saw those side effects. So there's always a bit of a tipping point between it working and people getting on with it, and then having the dose too strong and people not getting on with it.
And then maybe this time last year, or maybe a bit earlier, Mounjaro hit the scene. And that seemed to me to be a game changer.
Yes, and it's a different class of drug. Okay. So Mounjaro, the drug name is tirzepatide, and it's 2 hormones. So it has the GLP-1, but it also has a gut hormone called GIP. And those two in combination have an additive effect. And the hormones themselves work in slightly different ways. So they're targeting different areas. So GIP also targets fat tissue and changes the way fat tissue is accumulated and metabolized. So that it's a different effect to the GLP-1. And those two in combination in trials showed an over 20% weight loss in people. So again, a big step up in terms of weight loss. And in terms of side effects, was actually pretty well tolerated compared to drugs that perhaps have a lesser effect from a weight point of view.
Okay, so 20% total body weight loss, that really is extraordinary. And how long do patients have to use the medication for to achieve that?
Yeah, so again, most of these trials run for a number of years, and it's both to look at how well they work, but also the safety of them. And for these trials, they're saying really that weight loss, that maximal weight loss, obviously you're looking at the higher doses, and really it can take up to 2 years to reach what might be the point when people stop losing weight. So it's not a medication that, only works in the first few months. It's often something you need to stick with for a longer period of time. But yeah, up to 2 years, people would be losing weight. And then most people reach a point, regardless of the dosing, where their weight loss steadies out.
Brilliant. And beyond weight loss, medical benefits?
Yeah, so the medical benefits you see are primarily related to simply losing weight. So we know excess weight is associated with over 200 different medical conditions. So as people lose weight, 5%, 10%, 15%, we see benefits to their blood pressure, their blood sugar levels. If they've got any fat in their liver, that starts clearing out. Things like sleep apnea, which are really common and associated with weight, that can improve. So people start seeing those effects really from 5% weight loss. But the more you get to the 15 and 20%, you're reducing those and also reducing risk of premature death from excess weight.
Okay. So these really are incredibly effective drugs. Who's allowed to use them?
So this is where there's always a lot of confusion. Yeah, because what you have is what a drug is licensed for. So this is where the companies do their drug trials. They do the drug trials, and then the licensing is based on the evidence from those. So both on how the drug works, but also the safety. So these medications, broadly speaking, are licensed and can be prescribed in people with BMIs of over 30 or a BMI of 27 and over with a weight-related medical condition. I've named a few, but there are a lot out there. What you then have is then what is actually available here in the NHS, and that's decided by NICE, which is the National Institute of Clinical Excellence. That sits outside of government, it sits outside of the NHS, and that looks at all medications. It looks at technologies you might use in therapies. It looks at the evidence the companies submit, it looks at the cost, and it then makes a decision on what should then be made available on the NHS. And so NICE has looked at these medications and said the most effective group and the cost-effective group for the NHS to prescribe this in, broadly speaking again, is a BMI of over 35 with at least one weight-related comorbidity. And once NICE has done that, it gets even more complicated, because then it's up to local regions, what we call integrated care networks. And those integrated care networks look over hospitals, GPs, communities, they look at everybody, and they then decide how they're going to implement those recommendations. And that's where, unfortunately, you can get some variability across the country about what treatments might be available. And this isn't just weight loss medication, this can be anything, because then each individual area can make their own decision on whether they have a medication available and how that's then done. In the case of weight loss medication, because so many people, well over 3 million people in the UK would be eligible based on a BMI of 35 and a weight-related comorbidity, it's well over 3 million. The NHS said we can't afford that, that's not feasible. And so they have agreed to this 12-year rollout plan, which is going to start in the first couple of years for people with a BMI of over 40 with at least 4 weight-related comorbidities out of a list of 5. So there's this big spectrum of availability from what can be privately prescribed, which is simply based on the license of the drug, through to what the NHS is allowed to do, which at the moment for Mounjaro specifically is a BMI of over 40 with 4 weight-related comorbidities.
Okay. So inevitably, people are going to have to get the medication through private doctors. Do you have any concerns about using it in the private healthcare sector? Concerns about maybe patients losing too much weight, losing muscle rather than just fat?
Yeah, so I think the first thing to say is it's, private companies are held to the same standards, so you still can only prescribe within what the license of the drug is for. So it's important that people give the right information and they have the right reviews to make sure it is safe to prescribe the drug, that they understand the side effects of the medication and are taking it within license, so the way it's supposed to be taken. Any method of weight loss, be it dieting or medication or surgery, results in some degree of muscle loss. That's kind of inevitable. And the studies show that you do get muscle loss with weight loss medication, but it's equivalent to what you lose muscle-wise actually in dieting and also with surgery. So it's in keeping with that. So we would always advocate, weight loss medication is just a tool. It's not the only thing that people can and should be doing for their health. So you need to, a good quality diet. If you're eating less, you need to make sure what you eat is quality. You need protein. Protein needs to be prioritized. Plenty of fluid. I would always advocate for a multivitamin tablet to be taken with weight loss medication, much like we do if someone has weight loss surgery, to make sure they're getting all the nutrients, vitamins, etc. in. And exercise, because exercise actually is not necessarily useful for weight loss, but really important for maintaining muscle and bone strength. It's good for your mental health. And it's very good if you do lose weight, in keeping that weight off.
We talked earlier about the side effects of the medication. Are there any other risks or concerns that patients should be aware of?
Yeah, so we do ask some really specific questions when starting medications like these. One is around family history or personal history of thyroid cancer. So we don't use it in people with those histories. The main side effect of GLP-1s we always directly counsel about is pancreatitis. So that's a condition where your pancreas gets very inflamed. People can get really unwell with that. And that is a risk. It's rare, but it's a serious side effect. So we always talk about it. We also see people with gallstone disease. That's probably more a factor of losing weight rather than the drug itself. But again, that's also a risk factor for pancreatitis, so we're also careful about that. So those are probably the major ones. And then I've touched on before the sort of more common side effects that just people to be aware of, like the nausea, the vomiting, obviously your appetite goes down and things like that.
But as you said earlier, these medications have been used in diabetic patients for 15 plus years. Generally they seem to be safe?
Yeah, so type 2 diabetes, they've been around for a very long time. The dosing, so how strong the dose is slightly different in type 2 diabetes. They tend to be the lower doses. But yeah, they've been very well tolerated. We see the same side effects of the nausea and things like that. But yeah, they're very effective and very well tolerated. And so yes, there are people in the community that have been on these drugs for well over 10 years. And type 2 diabetes is a chronic disease just like obesity is. And so the aim is that they will remain on those medications. There's no sort of finish date on taking them.
Exactly. So how do you see the future? And there's a lot of people out there who don't like injections. Is there an oral form on the horizon?
Obviously, there's a huge amount of interest in weight loss medication at the moment, particularly having some on the market that have been so effective. So we know in development there are tablet versions of these medications, which is, of course, very appealing to people who don't like injections or perhaps are unable to inject themselves or don't have someone to do it for them. And we're probably looking at maybe as soon as next year for that. And then, of course, we've talked about 1 and now 2 gut hormones, but there are lots of other gut hormones that people are looking at in different combinations. So different combinations of 2 hormones and even 3 hormones in combination to work together to get weight loss. So it's quite an exciting time because there's well over 100 different medications in development at the moment. They won't all come to market and they may or not be available through the NHS, for example. But yeah, there's a lot on the horizon in the next few years.
And do you see those medications giving even better weight loss than Mounjaro?
So I think there's probably a limit in reality. And again, that comes back to that balance between strength of treatment and side effects. But I think we should expect at some point that we'll breach that 30% total body weight loss. It's a bit difficult to know how those combinations will look though in real terms, because I think there will be that limit on side effects and tolerability at some point.
Yeah, so the future looks bright. So Eveleigh, back in September, unfortunately the price of Mounjaro increased, and for some people it became unaffordable. Are there alternative medications that they could use that are maybe cheaper?
Yeah, so at the moment, Mounjaro is now the most expensive weight medication available through private. Obviously, it's also the most effective. So people could choose, because that's a 2 hormone drug, to change to the single GLP-1s like Wegovy. Obviously, the milligrams are slightly different, so I would always recommend that's done through a medical professional, but it is feasible to switch from one to the other.
Okay, so under supervision, that's a very reasonable thing to do.
Yeah, I would always recommend under supervision, because although the devices look very similar, it is different milligrams, it is a slightly different drug, and it would always be worth making sure that individual understands the differences and any side effects they need to be looking out for as well.
Eveleigh, I've really enjoyed our conversation today. It's been great to have you with us. Brilliant. In the next episode, Eveleigh and I are going to be joined by Dr Mel Rendell, a clinical psychologist, and we're going to discuss the causes of obesity, the genetics that underpin it, the food environment that we live in that makes it so difficult, and the psychological issues that can drive weight gain. So we look forward to seeing you next time. If you want to see our other episodes, they're all on our YouTube channel.